Hello everybody. Haven't we come across people who give a history of fractures from minor traumas? They give a very small history of a fall from a little height or missing a staircase and falling down or a slip in the bathroom, and they suffer from fractures of spine, clavicle, wrist or hip joint. This is more commonly seen in elderly people and even in middle-aged women. This very presentation is seen in osteoporosis. The question is, why should such a trivial trauma give rise to fracture of bone? The answer to this is, osteoporosis is a disease which is characterized by loss of bone mass. Loss of bone mass means weakening of the bone, loss of strength of the bone. Let us first take a look at a normal bone. Bone is made up of protein called as type 1 collagen. Type 1 collagen. Collagen is composed of amino acid sequence. 3 such peptide chains are wound together in a triple helix to form a collagen molecule. Many collagen molecules form collagen fiber. The collagen fiber are further processed and laid down in the extracellular space. The fibers are then linked to one another by pyridinium crosslinks, which offer strength to the bone. In this way, a lamellar bone, that is, a thin layer or a plate of tissue, is generated. Such a bone is called as lamellar bone. After this, mineralization of the bone occurs by deposition of calcium and phosphate crystals between the collagen fibrils, which further fortifies the bone strength. Thus, as bone is formed, it acquires a solid outer surface called compact bone or cortical bone, which is dense and which envelopes around an inner sponge bone called trabecular bone. As shown in the picture, the cortical bone comprises of concentric lamellae of bone tissue surrounding a central canal that contains blood vessels. A few osteocytes are seen embedded in them. This structure is called as Haversian system or osteon. The inner trabecular or cancellous bone consists of an interconnecting meshwork of trabeculae. Trabeculae means columns or bands. The trabeculae are separated by spaces that are filled with bone marrow. The trabeculae consists of 3 types of cells: osteoblasts, osteocytes and osteoclasts. The osteoblasts are cells of mesenchymal origin and are responsible for bone formation. Osteocytes are derived from osteoblasts and they become embedded in the bony matrix. The osteoclasts are responsible for bone resorption. Bone resorption means a process by which something is removed or reabsorbed. Osteoclasts have their precursors that are present in the peripheral blood. The skeleton is shaped during growth years and it is repaired during adult life. This process is called as bone remodeling. The body undergoes continuous wear and tear. The damaged tissue has to be removed and replaced. Let us take a look at this process of remodeling. Remodeling starts with attraction of pre-osteoclasts present in the peripheral blood to the target site, that is, the site of microdamage. This osteoclast precursors differentiate into mature osteoclasts. The osteoclast then resorbs the bone by secreting hydrochloric acid and proteolytic enzymes. It dissolves the minerals and degrades the bone matrix of the damaged area. When resorption is complete, the osteoclasts undergo programmed cell death. Now, bone formation begins. The mature osteoblasts deposit a new bone matrix in the resorption lacunas. This is followed by mineralization and calcification of the new bone to form a mature bone. If you find the content of this video useful, please hit the like button. If you want to further see videos of similar contents, do subscribe. Don't forget to share with friends and folks. Thank you. In osteoporosis, there appears to be a disturbance of normal balance between bone formation and bone resorption. The bone resorption is normal, but there is a decrease in bone formation. There is a reduction in the number and size of the trabeculae and in the number of osteoblasts present. There is reduction in the thickness of the cortex. Osteoporosis is a structural change in the bone whereby the supporting tissue is reduced in amount but remains highly mineralized. It is a disorder of protein metabolism which is reflected in abnormal trabeculae formation, but the trabeculae are normally calcified as the metabolism of calcium is normal. Thus, there is a decrease in the bone density and bone mass, making the bone porous and reducing the mechanical strength of the involved bone. This graph shows changes in bone mass with age in both men and women. In normal individuals, bone mass increases during skeletal growth to reach a peak between ages of 20 and 40 years, but falls thereafter. Bone mass and bone loss are regulated by a combination of genetic and environmental factors. Genetic factors account for variance of 80% in peak bone mass and bone size and bone turnover. Environmental factors such as exercise and calcium intake during growth and adolescence are important in maximizing peak bone mass and in regulating rates of bone loss later in life. Another thing to be noted is the rate of bone remodeling is also regulated by circulating hormones. As seen in the chart, hormones like estrogen, testosterone, calcitonin, parathyroid hormones play an important part in bone gain by inhibiting osteoclasts and stimulating osteoblasts. Thyroid hormone, glucocorticosteroids cause bone loss by inhibiting osteoblasts and stimulating osteoclasts. Thus, in women, postmenopausal osteoporosis may result from ovarian insufficiency with diminution of estrogen secretion. Similarly, a deficiency of testosterone in men suffering from hypogonadism also lead to osteoporosis. A hormonal imbalance as seen in endocrinal diseases like acromegaly, gingitism, hypothyroidism, cretinism, myxedema, thyrotoxicosis, Cushing's syndrome can also lead to osteoporosis. Malnutrition, malabsorption syndromes, severe protein deficiency, abnormal protein loss, vitamin C deficiency, calcium deficiency, hypercalciuria are nutritional factors which lead to osteoporosis. These nutritional factors are often seen responsible for senile osteoporosis. Mechanical factors like prolonged bed rest or immobilization of the whole body or a part of it, as seen in many conditions like fractures, postoperative convalescence, tuberculosis, rheumatoid arthritis, anterior poliomyelitis, traumatic paraplegia, all lead to a general or local osteoporosis. Smoking has a detrimental or a bad effect on bone mass density. Female smokers have an earlier menopause, comparatively earlier menopause, and hence become more susceptible to osteoporosis or porous bones. Alcoholism is a recognized cause of secondary osteoporosis. Like any other disease, osteoporosis too is a multifactorial one. Often there is an interplay of many factors to promote the disease. It is important to mention that inflammatory diseases in which there is release of pro-inflammatory cytokines, and also in cancer where there is release of tumor necrosis factor and lymphotoxins, often lead to osteoporosis. Not to forget the environmental toxins and body oxidation due to modern lifestyles. Lastly and importantly, emotional stress is also operative in evolution of osteoporosis. Basically, osteoporosis is an asymptomatic disorder. The patient usually do not come to the clinician until and unless some complication takes place. Fracture is the most common complication which brings the patient to the clinician. Dorsolumbar spine is the most frequent site of fracture, followed by fractures of femur and Colles fracture. Loss of height has been noted in many patients. There may be a thoracic kyphosis and there may be approximation of the rib margin to the iliac crests. Some of the patients may present with pain. Pain is in nature of backache which radiates around the trunk and down the lower limbs. It is aggravated by movements of jerking. Now let us take a look at the investigations and diagnosis of osteoporosis. X-ray is diagnostic. Decreased bone mass is evident in X-ray, but 30% of bone mass must be lost before it is recognized on an X-ray. The cortex of the long bone becomes thin and the cancellous bone becomes less dense. Involved bone has a ground glass appearance due to loss of definition of the trabeculae. Healing of a pathological fracture is usually accompanied by very little callus formation. Measurement of bone mineral density are necessary to make the diagnosis of osteoporosis. Two types of bone densitometry are available: ultrasound based and X-ray based. The preferred technology is dual energy X-ray absorptiometry, also known as DXA scan. The preferred site for measurement is the lumbar spine and hip. Bone densitometries work on the principle that The calcium in the bone attenuates the passage of X-ray beams in proportion to the amount of minerals present. By comparing the degree of attenuation with known standards, the bone mineral density values can be estimated for various skeletal sites. This is absolute bone mineral density. Besides this, the DXA scan also provides T scores and Z scores. Once diagnosis of osteoporosis is made, it is important to identify predisposing causes, both primary and secondary. Routine biochemical and hematological screens should include blood calcium levels, blood vitamin D levels, thyroid functions, parathyroid hormone levels, estrogen in women, especially who are below the age of 50 years and are suffering from osteoporosis, testosterone in all men who are suffering from osteoporosis, immunoglobulins and ESR. Transiliac bone biopsy is only required in patients with early onset osteoporosis. Lastly, watch out for symptoms related to neoplasms and tests should be done accordingly. Treatment mainly depends on the cause of the condition. The main objective is to reduce pain and prevent fractures. Treatment can be divided into two groups: medical treatment and orthopedic treatment. Medical treatment includes 1. Exercises. Increased guarded exercises with limited weight bearing, which acts as a stimulus to bone formation. Proper physiotherapy in this respect is highly beneficial. When the patient suffers from malnutrition and prolonged disease, high protein diet increases the formation of organic matrix of the bone. Calcium supplementation causes improved bone mineralization, and vitamin D supplementation increases the calcium absorption from the gut. Fluoride makes the crystallinity of the bone greater so that bone resorption is slowed down. Bisphosphonates or alendronates are currently market leading drugs for osteoporosis. They are given cyclically in daily doses for 2 weeks every 3 months for about 2 years. Bisphosphonate therapy results in a decrease in bone resorption. Raloxifene is yet another drug which binds to estrogen receptors and inhibits osteoclastic bone resorption in a patient with postmenopausal osteoporosis. However, it is not considered as first line of treatment as it has its own aftermath. Hormone replacement therapy is considered as second line of treatment in both men and women, and because safer alternatives are available. Parenteral administration of calcitonin helps in building of bone mass and also acts as an analgesic. Orthopedic surgical intervention is undertaken only in cases of fracture. Often, surgery is followed by exercises and physiotherapy. To prevent pathological fractures in susceptible identified individuals, various belts and bracings are used, particularly for the spine.